Hello folks, and welcome to week 2 of BI 340 Medical Assisting. Today we're going to focus on physical examination, chapter 21 in your textbook. And the success to any course really involves understanding the objectives within that lesson. So some of the learning objectives for this particular lesson on physical examination includes 1. Describe the components of the patient's medical history and how to collect that history information. This will be expected of you before the provider enters the room. Do the following related to understanding and communicating with patients. Discuss how to successfully understand and communicate with patients and display sensitivity to diverse populations. Demonstrate therapeutic communication feedback techniques to obtain information when gathering a patient history. Obtain and document patient information. Respond to nonverbal communications when interacting with patients. Understand and compare open-ended versus closed-ended questions. I'm going to do the following related to the patient interview. Discuss the patient interview. Identify barriers to communication and their impact on the patient assessment, and maybe how to overcome some of those barriers as well. Detect a patient's use of defense mechanisms and the resultant barriers to therapeutic communication. Demonstrate professional patient interviewing techniques. Number 4, let's discuss the use of therapeutic communication techniques with patients across the whole lifespan, from childhood to teenager to young adult to elderly. Compare and contrast the signs and symptoms, understanding the difference between the terms signs and symptoms, and some examples of those as well. Number 6, knowing how to document patient care accurately in the medical record. Number 7, doing the following related to the physical examination. Outline the medical assistant's role in preparing for physical exam, and summarize the instruments and equipment the provider typically uses during a physical examination. Number 8, identify the principles of body mechanics and demonstrate proper body mechanics, especially when you need to physically help lift or assist a patient from a wheelchair to the examining table. Number 9, outline the basic principles of gowning, positioning, and draping a patient for exam. Also describe how to position and drape a patient in different examining positions while remaining mindful of the patient's privacy, comfort, and modesty. Number 10, describe the methods of examination and give an example of each one. And number 11, outline the sequence of a routine physical examination, and also preparing for and assisting in the physical exam of a patient correctly, completing each step of the procedure in the proper sequence. Now, the first step in assessing a patient or getting to know a patient is collecting some of their history and documenting it as such. So a new patient is usually asked to complete a health history form. Sometimes it's done online, sometimes it's done in person. Some patients may need assistance with it. This form is useful for diagnosing and treating the patient. Self-history also allows the patient to be more involved and proactive in their own health care. The form may be mailed to the patient's home before the appointment, or may be completed in the office during the first visit, or it may be sent to them online, electronically. Some healthcare facilities use electronic forms. These can be emailed to the patient or texted to the patient before their first appointment and incorporated into their electronic health record. The patient may also be able to complete the form online through what's called a patient portal, which is very common these days. If a paper form is used, it can usually be scanned into the patient's electronic health record after it's completed. If you're responsible for taking a portion of the medical history, conduct the interview in a private area, free of distractions and where others cannot overhear anything. Remember, patient privacy is a very, very important concept in medical care. Patients will not talk freely where they may be overheard or interrupted. Legally and ethically, the patient has the right to privacy, and access to the patient health record is permitted only for healthcare workers directly involved in the patient's care, or individuals the patient has specifically designated to receive that information. It is all part of the Health Insurance Portability and Accountability Act. So listen to the patient. Do not express surprise or displeasure at any of the patient's statements. Sometimes patients' complaint or the patient's remarks may contradict your thoughts, values, and belief systems, but you need to keep that to yourself. Remember, you're not there to pass judgment, but just to collect medical data. Medical assistants should document the information in an organized manner exactly as it's given to the patient without opinion or interpretation. Documentation can include the following: the purpose of the patient's visit, written as a chief complaint. The chief complaint is usually documented in the patient's own words and is the main reason for that particular visit for that day. The patient's vital signs, height and weight, and pain scale using a tool used as a severity of 1 to 10. There are multiple components of a patient's medical history that needs to go into the chart, and usually before the provider interacts with that patient. Now, your medical history forms are going to vary depending on the provider's preference, the practice specialty, and their electronic health system. The most commonly used medical history form includes these basic components. The database. This is a record of the patient's demographic information, their name, their address, their date of birth, along with history, physical examination, and initial laboratory findings. As new information is added, it becomes part of this database. As we mentioned before, the chief complaint is the purpose of the patient's visit. Generally, this should be documented in the patient's own words and with the use of quotation marks. History of present illness. If it's a new complaint or a new problem, the medical assistant should gather as much information about the health problem as possible and document it precisely or concisely in chronologic order. Then back that up with the patient's past medical history or past history, a summary of the patient's previous health issues. It includes dates and details about the patient. Anything from unusual childhood illnesses, such as maybe rheumatic fever or chickenpox, major illnesses such as cardiac issues, diabetes, seizures, any surgeries in the past. Allergies is a very important question to ask. Allergies to food, drugs, medications, cosmetics, or even environmental allergies. Any accidents recently or in the past, or any potential for accidents to occur at home. And then ultimately also immunization records, things such as childhood immunizations such as measles, mumps, rubella, varicella, Tdap, and current vaccinations such as influenza and COVID. So to provide high quality patient care, we must communicate effectively with the patient and provide a warm, caring, and sensitive environment. Positive reactions and interactions with this patient are vital. Medical assistant must always remember that each patient is an individual with certain anxieties, certain stresses. These anxieties often cause people to act and react in different ways. Therefore, effective verbal and nonverbal communication with each patient is essential. Healthcare professionals accept this responsibility of developing a helping relationship with their patients. It's assumed once you go on the job. The interpersonal nature of a patient-medical assistant relationship means that the focus should be on the patient's needs. A medical assistant can bring out either a positive or a negative response simply by the way he or she treats and interacts with patients. You are usually the first person with whom the patient communicates, therefore you play a vital role in a therapeutic patient interaction. Another important aspect of communicating with patients is an awareness of self-boundaries. When working in healthcare, it's important to develop a solid professional relationship with our patients. By establishing realistic self-boundaries, that relationship can be protected. It's important to keep the focus on the patient. When you work with patients you're seeing frequently, it's easy to start thinking them as friends and comrades. With a friend, you're likely to share personal information that's not appropriate to share with a patient. Patients may feel like they cannot share important health-related information because you are their friend and it would be embarrassing. And now they may feel like they're being judged. So just think about that. Self-boundaries can also be thought as of professional boundaries. You need to treat the patient with respect and keep the relationship professional. Be friendly to patients and always keep the focus on the patient. It's very important to remember sensitivity to diverse patient groups. Most healthcare facilities have a diverse patient population. We have a diverse population right here at the campus in Queensboro. The diversity could be based on race, age, culture, religion, or physical qualities such as being deaf or hard of hearing. Whatever the origin of the diversity, practicing respectful patient care is extremely important. Empathy is the key to creating a caring, therapeutic environment. Empathy is different from sympathy. A medical assistant who is empathetic respects the individuality of the patient and attempts to see the person's health problem through his or her eyes. The medical assistant also recognizes the effect of all holistic factors on the patient's well-being. Empathetic sensitivity to diversity requires you to examine your own values, beliefs, and actions. You cannot treat all patients with care and respect until you first recognize and evaluate your own personal biases. We think and act in a certain way for many reasons, and we all have our biases. It's a given. The first step is understanding the process is to evaluate your individual value system. Why do you have certain beliefs and attitudes about the worth of individuals or things? Many factors influence the development of a value system. Value systems begin as learned beliefs and behaviors. Families and cultural influences shape the way we respond to a diverse society. Other factors that influence reactions include socioeconomic and educational backgrounds as well. To develop therapeutic relationships, you must recognize your own value system to determine whether it could affect how you interact with patients. Preconceived ideas about people because of their race, religion, income level, ethnic origin, sexual orientation, or gender can act as barriers to the development of a therapeutic relationship. You cannot treat your patients empathetically unless you can connect with them in some way. Personal biases and prejudices are huge barriers to development of that therapeutic relationship. Communication is an interactive process involving the sender of a message, the receiver, and feedback. Feedback is a crucial component to confirm that the message was received. The message can be sent by a number of methods, either face-to-face communication, telephone, email, text, or letter. Feedback lets us know that the receiver got the message and how he or she interpreted it. This completes the communication cycle by providing a means for us to know exactly what message the patient received and whether it requires clarification. For example, as medical assistant, one of your responsibilities would be to provide patient education on how to prepare for certain diagnostic studies. Let's say you have to explain to an older adult patient how to prepare for a colonoscopy. You provided a detailed explanation of the preparation procedure and a handout explaining the step-by-step process. How do you really know whether the patient understands? You ask the patient to provide feedback by explaining the process back to you. As a member of the healthcare team, you must become an effective communicator. You will play a vital role in collecting and documenting patient information. If your methods of communication are faulty, then the quality of patient care may be seriously impaired. Effective communication also involves active listening techniques. Hearing is a physical act. Someone speaks and we hear what the person has said. Listening is something we consciously choose to do. Active listeners go beyond hearing the patient's message to concentrating, understanding, and listening to the main points. Active listening techniques encourages patients to expand on and clarify the content and meaning of their messages. These techniques are very useful communication tools when a patient is agitated or upset. They help the medical assistant clarify the important details of the patient's chief complaint. So, 3 processes are involved in active listening: restatement, reflection, and clarification. Restatement is simply paraphrasing or repeating the patient's statement with phrases such as, "So my understanding of what you're saying is," or "You're telling me the problem is." Reflection involves repeating the main idea of the conversation while also identifying the sender's feelings. For example, if the mother of your patient is expressing frustration about her child's behavior, a reflective statement identifies that feeling with the response such as, "Sounds like you're frustrated about," or if a patient who has been newly diagnosed with insulin-dependent diabetes shows anxiety about administering injections, maybe an appropriate reflective statement recognizes the patient's feelings. For example, "So you appear to be anxious about," So reflective statements clearly demonstrate to patients that you're not only listening to their words, but you're also concerned and are attending to their feelings. Clarification seeks to summarize or simplify the sender's thoughts and feelings and to resolve any confusion in the message. Questions or statements that begin with, "Oh, give me an example," or "Please explain to me about," or "So what you're saying is," helps patients focus on the chief complaint and give you the opportunity to clear up any misconceptions before documenting patient information. So listening is not a passive role in the communication process. It's active and it's demanding. You cannot be preoccupied with your own needs or you will miss something important. For the duration of the patient interview, no one is more important than this particular patient. Listen to the way things are said, the tone of the patient's voice, and even what the patient may not be saying out loud, but is saying very clearly with body language. So, most experts say that about 90% of communication is nonverbal. Much of what we communicate to our patients is conveyed through the use of body language. Our nonverbal actions, such as gestures, facial expressions, and mannerisms, are learned behaviors that are greatly influenced by our family, friends, and cultural backgrounds. The body naturally expresses our true feelings. Most of the negative messages communicated through body languages are unintentional. It's important to remember while conducting patient interviews that nonverbal communication can seriously affect the therapeutic process, either for good or for bad. The purpose of observing nonverbal communication is to become aware of the message conveyed by these behaviors rather than the words. This enables you to adapt your behavior to these feelings. You can deliberately select your response, either verbal or nonverbal, to have a favorable effect on others. The favorable effect may consist of the following: providing emotional support, conveying that you care, diffusing the patient's fear or anger, providing an invitation to release pent-up feelings by talking about the situation that aroused the feelings. So now remember, nonverbal behavior, such as your body language, can have either a positive or a negative effect on patient interactions. Positive nonverbal behaviors enhance the patient's experience in the healthcare setting. Communication experts recommend the following. So when gathering a health history, lean toward the patient to show interest. Face the patient squarely at eye level to make the process more comfortable and to demonstrate sensitivity and empathy. Eye contact, within reason, is essential for therapeutic communication unless the patient is from a culture that discourages this, and this is something you'll probably have to feel out over time. A closed posture, crossed arms or legs, may indicate disinterest. Be sensitive to the patient's personal space when possible. Maintain a comfortable distance from the patient, at least an arm's length, but not too far away when conducting the interview. Be careful with body gestures such as hand and arm movements. Gestures such as nodding your head when the patient talks can display interest, but too much body movement can be distracting. Think about your tone of voice. Your tone of voice should reflect your interest in speaking to the patient. Speaking too quietly or too loudly can distract from therapeutic communication. It can make the patient feel like you're speaking at them or talking at them rather than with them. Continually observe the patient's body language during the interview. Watch for signs of confusion, boredom, worry, and so on so that you can respond appropriately. Documenting in the EHR while the patient's telling you their history can be distracting for both the medical assistant and the patient, can also show the patient that you're disinterested. Remind yourself to look at the patient frequently and use encouraging body language to maintain a personal interaction. So, an open-ended question or statement asks for general information or states the topic to be discussed, but only in general terms. This communication tool is useful in the various ways: to begin an interview, to introduce a new section of questions, or whenever the person introduces a new topic. Closed-ended questions are more direct, and they ask for specific information. This form of questioning limits the answer to one or two words, in many cases just yes or no. Use this form of question when you need to confirm specific facts, such as when talking about past health problems. For example, do you have a headache? What is your date of birth? Have you ever broken a bone? The initiation of the interview is the time to introduce yourself, to identify the patient, and determine the purpose of the interview. If you're nervous about how to begin, remember to keep it short. The patient's probably nervous too and is anxious to get started. Address the patient by his or her last name and give the reason for the interview. For example, Mr. Coleman, my name is Stacy. I am a certified medical assistant who works with Dr. Perez. I have some questions to ask you about your health history. After the brief introduction, move on to the body of the interview. This is when you use various therapeutic communication techniques to determine things such as the reason for the patient who is seeking healthcare, the patient's perception of the problem, the characteristics of the problem, and the patient's expectations of care. During this time, use active listening skills, meaningful silence, congruent verbal and nonverbal communication, and a combination of open-ended and closed-ended questions to gather the details of the patient's history and health problems. And then finally, conclude the interview by summarizing the results of your interaction. The closing of the interview should clarify the patient's chief complaint, the purpose of the visit, and the patient's expectations of care. This is the patient's opportunity to add any additional details or to explain further the characteristics of their particular health problem. So to recap a couple of points, preparing the appropriate history and physical environment involves a couple of things. Ensuring privacy, which is very important. Make sure the doors are closed, the curtains are drawn. If anybody doesn't need to be in that room, politely ask them to excuse themselves. Never ask a patient their problem or their complaint in the middle of the lobby or in public view. As best as you can, prevent interruptions. Prevent interrupting other medical assistants and providers unless it's an emergency involved. Try to prepare the surroundings as comfortably as possible. And take judicious notes. However, remember to constantly interact with the patient and not just keep your face within the medical chart. Keeping the questions open-ended, direct to close questions. Remember your active listening techniques. Sometimes appropriate silence gives the patient a chance to reflect on what they want to say next. We talked about establishing guidelines, acknowledgement of the patient's problem, restating their complaint, reflecting, and summarizing. There are some processes and habits that can be very inappropriate during a patient interview. For example, providing unwarranted assurance. If a patient has a lump or a serious condition that they're concerned about, telling them everything is going to be okay, although maybe well-meaning, is not appropriate, because if a person notices a big mass in their neck, they don't really think everything's going to be okay. And it's almost like you're making a false promise just to make them feel better. It's never appropriate for the medical assistant to give medical advice unless it's approved by the provider. If you want to give advice on a certain recipe or a certain movie to watch, that's a different story. But in the medical setting, leave the advice to the professional. Don't baffle your patient using medical jargon and terminology. It's only going to cause distrust and discontent among the patients. Don't ask leading questions. Okay, keep the questions open-ended. Leading questions, for example, so is the headache sharp? Did you vomit 3 times? Patients will tend to feel drawn in and answer the way they think the questions want to be answered. Keep your discussion brief. Don't overtalk the patient. The patient's there to talk about themselves and not there to hear about your particular stories or life situations. And finally, think about defense mechanisms. Many individuals respond to anxiety-provoking situations by automatically relying on defense mechanisms. Defense mechanisms are used consciously or unconsciously to block an emotionally painful experience. It's understandable that patients facing a traumatic diagnosis or difficult treatment feel the need to protect themselves from the reality of the situation. Ensuring compliance with treatment becomes an issue if the patient's in denial, projecting feelings onto the healthcare worker, repressing the need for treatment or diagnostic follow-up. The medical assistant needs to be sensitive to the patient's use of defense mechanisms and capable of trying to work with them. So sometimes patients use defense mechanisms to protect themselves from a situation that they can't manage psychologically. Defense mechanisms may hide any of a variety of thoughts of feelings, anger, fear, sadness, despair, or helplessness. A patient who uses a defense mechanism can be difficult to deal with. If the medical assistant is aware of the patient's need for psychological protection, he or she may be able to find a way to provide care for the patient while maintaining a therapeutic relationship. Um, some examples of defense mechanisms are as follows. For example, denial. The patient completely rejects the information. It's like, I couldn't possibly have breast cancer. You got to be mistaken. Suppression. The patient is consciously aware of the information or feeling but refuses to admit it. For example, I don't think this test is accurate. My mammograms are always normal. Reaction formation. The patient expresses their feelings as the opposite of what they really feel. For example, they may be angry at the medical assistant for insisting that the biopsy be scheduled, or may express the opposite emotion. I appreciate you trying to help me, but I can't come to the hospital that day. Something like projection, where the patient accuses someone else of having the feelings that she has. For example, a patient's angry about the diagnosis. She may say to the medical assistant, you don't have to lose your temper about this, or it may even accuse the medical assistant of being unprofessional or wrong demeanor. Rationalization. The patient comes up with various explanations to justify her response. I think the results are wrong. I want to follow up with another doctor. I think it was done wrong. Undoing involves a patient trying to reverse a negative feeling by doing something that indicates the opposite feeling. For example, the patient feels angry and violated about the diagnosis, but she finds those feelings unacceptable. She may say, don't worry, dear, I'm not upset with you for telling me about this. Regression. The patient reverts to an old, usually immature behavior to vent her feelings. Instead of discussing the diagnosis and needs for treatment, she just storms out of the office because they don't like what they're hearing. Or they just tell you, well, I can't do this because I have other things on my schedule. Something called sublimation. The patient redirects their negative feelings into a social, productive activity. For example, eventually someone becomes an active member of a local support group based on a diagnosis they receive. So the key to effectively communicating with patients is using an age-specific approach. Given the age and developmental level of your patient, how can you best interact with the person and with the significant family members? Take, for example, Tasha. A 2-year-old patient is scheduled for a physical examination. How can you best interact with her and her father or mother to ensure that the history phase of the visit is complete and accurate? Therapeutic use of nonverbal language is essential to interacting with children of all ages. Getting down to the child's level, establishing eye contact, using a gentle but firm voice are always ways of gaining the child's confidence and cooperation. Children fear the unknown, so explaining all procedures with language that the child understands is important. At the same time, the medical assistant must communicate with the child's caregiver so that he or she can contribute to the intake process. There's some following guidelines you can go by to obtain the health history of a child. For one thing, make sure the environment is safe and attractive. Don't keep children and their caregivers waiting any longer than necessary because children will become anxious, distracted, and restless. Do not offer a choice unless the child can truly make one. If part of the treatment requires an injection, asking the child whether she would like the shot now is most likely going to get an automatic no. However, if you give her a choice of stickers after the injection, that's a little more appropriate. Praising the child during the examination helps reduce anxiety and boost self-esteem. When possible, direct questions to the child so that he or she feels more of the process. Involving the child in the examination by permitting him or her to manipulate the equipment may help relieve anxiety. If possible, use your imagination. Make it a game. That'll help with the assessment or the procedure. A typical defense mechanism seen in sick or anxious children is regression. The child may refuse to leave the mother's lap, or they may want to hold a favorite toy during the procedure as a comfort measure. Look for signs of anxiety, such as thumb sucking or rocking during the assessment, and encourage caregivers to be involved in the process to help to make the child feel as safe as possible. And of course, listen to the parents' concerns and respond truthfully to questions. Older children may also have difficulty during the health visit. To help school-age children gain a sense of control, give them the opportunity to make certain decisions about treatment. For example, take Heather, 13-year-old patient with diabetes. She could be given a choice of having her father present during the visit or not. Or if she requires an insulin injection, she could choose the site of the injection or perhaps administer the medication herself. This gives the medical assistant an opportunity to observe her technique and allows Heather to exert her independence. Privacy is an important issue to consider with older children, especially adolescents. During the physical examination, respect privacy by keeping body exposure to a minimum and adequately preparing the child for procedures and positions. In addition, older children want to know what's going on during the examination, what to expect, and what the feelings mean. Therefore, keeping them informed in a language they can understand is important. Teen patients should always be encouraged to ask questions, which should be answered as completely and clearly as possible. Take every opportunity to teach your patients, regardless of their age, about their disease and to share information about significant wellness factors. So now, after the interview is complete, the patient is escorted to an examination room, or it could be in the same exam room, and prepared for the physical examination. During the examination, the healthcare provider methodically checks all the body systems, or sometimes just checks focused body systems depending on the complaint. For each system, the provider mentally compares a system with established norms. Normal and abnormal findings are usually documented in the patient's health record. The physical examination typically starts with the head and progresses downwards to the feet. However, the order may vary, and again, the exam may be focused on one or two body systems based on the patient's signs and symptoms. And with that, it's important to understand the difference between the sign and a symptom. A symptom is something that's subjective. It's basically what the patient tells you or is experiencing or going through. It cannot be objectively observed. That's what a sign is. A sign can be either seen, heard, felt, even smelled on a patient, and it's usually recorded in the chart. And speaking of recording in the chart, there are various documentation guidelines that you should be familiar with, depending on the healthcare provider's preference and on the EHR system. Certain documentation procedures have been standardized to meet legal requirements for maintaining medical records accurately and concisely. Complete, accurate documentation is one of the primary responsibilities of a medical assistant. So some guidelines are as follows. Check the name on the record and make sure the information being documented is recorded on the correct form in the correct patient's health record or in an EHR system, and that the correct information is recorded using the correct system prompts. Confirm the patient's identity by checking his or her date of birth. The month, day, and year must precede the entry. Many facilities also require the time of the documentation or a timestamp. All unusual complaints, symptoms, or reactions must be noted in detail. Include complete information about the onset, duration, frequency, and associated signs and symptoms of each complaint. Describe the objective data, such as the presence of a wound, using correct anatomic medical terminology, which you probably had a separate course in. If the patient's report is complaint of pain, record the quality. Is it sharp, stabbing, dull, and intensity of the pain using a pain scale of 1 to 0. 1 being the least amount of pain, 10 being the worst pain in the world. If the patient's comments are entered in the patient's own words, enclose them in quotation marks. Document the complete medication history, including not only prescription drugs, but over-the-counter medications, birth control, supplemental medications. Document if they're taken intermittently on a regular basis, its last dose taken, and any other pertinent details. Record details about the patient's previous medical history on the current chief complaint. When entering information in the medical record, sign the entry including the appropriate initials after your name. Learn to be observant and note anything that seems pertinent. Be very careful as far as using abbreviations, symbols, and terminology. Now, the purpose of the physical examination is to determine the patient's overall state of well-being. All major organs and body systems are checked during the physical exam. So the provider examines the entire body. He or she interprets the findings. By the time the examination has been completed, the provider has formed an initial diagnosis of the patient's condition. Often, laboratory and other diagnostic tests are ordered to supplement the provider's clinical diagnosis. The results of these tests are used to do the following: refine the patient's diagnosis, help the provider plan or revise treatment for the patient, evaluate and maintain current drug therapy, or determine the patient's progress. Before the examination, the medical assistant has the opportunity to make sure the patient feels comfortable during the examination process and that all necessary medical information has been obtained. The medical assistant's duties include preparing and maintaining the examination room and equipment, preparing the patient, and assisting the provider during the physical examination. The medical assistant is responsible for making sure the examination room is ready for any procedure that might be performed during the physical exam. The area should be comfortable as possible for the patient and free of any potential dangers such as contaminated equipment, unlocked drug cabinets, or exposed sharps. You should do the following things to prepare the examination room. Make sure to stock with all the equipment and supplies. Check the expiration dates. Discard expired materials such as medications or other medical equipment. Ensure the room is private, well lit, and a good temperature. Clean and disinfect the room between patients and daily to avoid infection. Be sure drapes, sheets, and gowns are ready for use. Arrange equipment for easy access, especially if you know it's a procedure that the provider is going to wind up performing. And always observe standard precautions. Make sure the examination room has all the materials required for observing standard precautions, including gloves, a sink with soap, paper towels, biohazard waste containers, sharps containers, and impervious face guards and drapes. Sharps containers must be replaced by the time they are 2/3 or 3/4 full as indicated by standard precautions. So now getting the patient ready for the examination includes taking care of paperwork before the patient enters the exam room and performing any related clinical skills. Now that may already be done for you by the front desk personnel, but it's still part of the responsibilities of the medical assistant. So make sure the health record is complete and that any needed consent forms have been signed. Document current medications, allergies, identify any medications that need refills. The medical assistant is not responsible for obtaining informed consent, but he or she should review the paperwork to make sure that informed consent forms were reviewed by the provider and that the patient has signed the forms. Introduce yourself, verify the patient's identity and address. Address the patient by his or her preferred name, making sure to show respect at all times. Pay close attention to the patient's nonverbal language to make sure that she understands what to expect. Obtain specimens, for example, urine or blood, if the provider has pre-ordered them or if this practice is part of office policy or something we sometimes call standing orders. Measure and record the patient's height, weight, body mass index, and vital signs. Conduct the initial investigation into the reason for the visit and explain the examination procedure to the patient. Be prepared to answer the patient's questions and ease any fears. If needed, refer the patient's questions to the provider. Ask whether the patient needs to empty his or her bladder before the examination, because a full bladder may interfere with the examination and may be uncomfortable for the patient. And if the patient needs to go to the bathroom before the examination, make sure that a sample is not needed by the provider beforehand. Help the patient physically prepare for the examination. Explain to the patient what clothing should be removed and in what direction to put the gown on. Provide a drape to ensure the patient's privacy and help is needed. Assist the patient into and out of various examination positions as needed. And throughout this sequence of events, explain what is happening. Consistently maintain the patient's privacy and confidentiality. Help the patient with dressing as needed after the examination, if it's needed at all. The medical assistant should also be prepared to help the provider complete the physical examination as comprehensively and efficiently as possible. During the examination, the provider may expect the medical assistant to do the following: hand out instruments and equipment as requested and provide supplies as needed. Alter the position of light source to better illuminate the area being examined and turn lights on and off during specific phases of the examination. Position and drape the patient during different phases of the examination. Assist in collecting and properly labeling specimens such as urine, pap tests, throat cultures. Conduct any diagnostic tests pre-ordered by the provider, including hearing and visual screening. Conduct follow-up diagnostic procedures as ordered, including an EKG, urinalysis, or phlebotomy. Document patient data in the health record, completing all forms required. And make sure that post-examination diagnostic procedures are scheduled, such as mammography, x-ray, or colonoscopy. The instruments typically used during the physical examination are shown in your textbook. They enable the provider to see, feel, inspect, and listen to parts of the body. All equipment must be in good working order, properly disinfected, and readily available for the provider's use during the examination. The instruments most frequently used for a physical exam are listed here in this slide. Physical examinations typically are performed from the head to the feet, and all the instruments listed here are in the order in which they would properly be used. For example, there's gauze, antiseptic wipes, specimen collections, lubricant tape measures, clean, non-sterile gloves, fecal occult blood testing supplies, percussion hammer, tuning forks. You'll be familiarized with all this equipment during the course of your lab session. An ophthalmoscope is used for inspection of the inner eye structures. Tongue depressors should be held down and they should be clean. An otoscope is used for examining the inner ear. Medical assistants should use proper body mechanics consistently throughout the work environment when sitting, standing, lifting, or carrying objects, pushing or pulling, or transferring patients. Without consistent application of correct anatomic alignment, injuries, especially lower back injuries, can easily occur. Proper body alignment begins with good posture. Maintaining posture requires a combination of muscle efforts. Good posture keeps the spine balanced and aligned while a person is sitting or standing. A person in good body alignment can maintain balance without undue strain on the musculoskeletal system. When reaching for an object, always avoid twisting or turning. Instead, move the feet to face the object needed. This prevents undue strain on the lumbar region. Do not cross the legs while sitting because this interferes with circulation of the legs and feet. When sitting, keep the popliteal area, the area behind the knees, free from the edge of the chair. Pressure in this area interferes with circulation and may damage nerves behind the knees. Do a mental check of your posture regularly. Hold the head erect, straight up, the face forward, the chin slightly up, the abdominal muscles contracted up and in, the shoulders relaxed and back, the feet pointed forward and slightly apart, and the weight evenly distributed to both legs with the knees slightly bent. Always be on the alert for poor body mechanics that may cause injury. There are times when patients may need assistance in moving from a chair to the exam table and back again. Patients can be transferred in multiple ways, but all should focus on correct body mechanics. If the patient's in a wheelchair, move the chair at a 45-degree angle towards the footrest that extends from the bottom of the exam table. Lock the wheels and lift the footrest of the wheelchair out of the way. Explain the procedure to the patient and ask for his or her cooperation and assistance. If one side of the patient is weaker than the other, always provide support on the weak side. Support the patient close to your body on the strong side with one hand under the axillary or armpit region and the other either grasping the patient's hand or holding the forearm. When bending, always bend at the knees and maintain the back's 3 natural curves, allowing for the leg muscles to help in lifting. Give the patient a signal and lift as the patient assists. Help the patient step up onto the footrest with the strong leg first, then pivot. Ease the patient down onto the table while bending your knees while keeping your back aligned. Make sure the patient is comfortable and safely positioned on the table. Draping the patient with a sheet or a gown protects the individual from embarrassment, maintains their dignity, and also helps keep the patient warm. However, the drape must be positioned so that it allows complete visibility for the examiner and does not interfere with the examination. During the general examination, each part of the body is exposed one portion at a time. For gynecologic and rectal examinations, the sheet is positioned on the diagonal across the patient or in a diamond shape to provide maximum comfort for the patient while allowing the provider to perform this examination. The following section describes a number of different positions used during the medical examination. First is the Fowler position. This is where the patient sits on the examination table with the head of the table elevated. Textbook may say 90 degrees, but sometimes we can make it anywhere from 45 to 90 degrees. This position is useful for examinations and treatments of the head, neck, and chest, and for patients who have difficulty breathing when lying down. The semi-Fowler position is kind of what we talked about just now. Semi-Fowler position is a modification of the Fowler position. The head of the table is positioned at about a 45-degree angle instead of a full 90-degree angle. This position is useful for post-op exams in patients with breathing disorders and patients suffering from head trauma as well. If you remember your anatomic terminology, in the supine position, the patient lies flat on the back, facing upward with the legs supported by the table extension. This position is used for full examination of the body from head to toe. In the dorsal recumbent position, the patient lies face upward with the weight distributed primarily on the surface of the back. This is accomplished by flexing the knees so that the feet are flat on the table. The position relieves muscle tension in the abdomen and may be used for examination or inspection of the rectal, vaginal, or perineal areas. This is also the position you want your patient complaining of abdominal pain to be positioned in to relax the stomach muscles. Patients should not be placed in a lithotomy position until the provider is in the examination room and ready for this part of the examination. When doing so, place the patient on his or her back with the knees sharply flexed and the arms at the sides or folded over the chest. Have the patient slide the buttocks down to the bottom edge of the table. Have them support the feet in the stirrups, placed wide apart and somewhat away from the table with the stirrup arms extended to match the length of the patient legs. If the heels are too close to the buttocks, the possibility of leg cramps increases. It's more difficult for the patient to relax the abdominal muscles. The Sims position is sometimes called the left lateral position. The patient is placed on the left side. The left arm and shoulder are drawn back behind the body so the body's weight is predominantly on the chest. The right arm is flexed upward for support. The left leg is slightly flexed and the buttocks are pulled to the edge of the table. Prone position is rarely used in the examination room. In the prone position, the patient lies face down on the table on the ventral surface of the body. This is the opposite of the supine position. It's another form of a recumbent position. You have to be careful placing patient in prone positions because this could be very uncomfortable for a patient, may make it more difficult for them to breathe and maintain the airway. And for the knee-chest position, the patient rests on the knees and the chest with the head turned to one side. The arms can be placed under the head for support and comfort, or they could be placed at the sides of the table of the head. The Trendelenburg position is rarely used in the ambulatory care setting, and it's also rarely used in emergency medicine, except in the cases of severe hypotension or shock. It can be achieved only if the examination table separates so the legs can be elevated higher than the head. So examinations are performed as both a routine confirmation of wellness and a means of diagnosing disease. Healthcare providers use 6 methods to examine the human body. The first one is inspection. During an inspection, the examiner uses observation to detect significant physical features or objective data, basically just by visualizing what's going on with the patient. Looking at things at the patient's general appearance, their outward state of health, to more detailed observations including their body contour, their gait, their symmetry, any visible injuries, rashes, color changes, anything that's readily visible to their eye. The term palpation, which means to feel, the examiner uses a sense of touch. Part of the body is felt with the hand to determine its condition or the condition of an underlying organ. Palpation may involve touching the skin or performing a firmer exploration of something maybe like the abdomen for underlying masses. Percussion involves tapping or striking the body, usually with the fingers or a small hammer. This will cause sounds, vibratory sensations, or involuntary reactions. Percussion can help determine the position, size, and density of an underlying organ or cavity. The examiner both hears and feels the effect of percussion. It's helpful in determining the amount of air or solid matter in an underlying organ or cavity. Auscultation involves listening. And for auscultation, the provider usually uses a stethoscope to listen to sounds from the body. Auscultation is a complex method of examination because the provider must distinguish between a normal sound and an abnormal sound. It's particularly useful for evaluating sounds originating from the lungs, heart, or abdomen. Mensuration is the process of measuring. Measurements that are recorded include height, weight, size, depth of a wound, strength, reflexes. Measurements are taken with a flexible tape measure, circular wound measurement device, or any other specialized piece of equipment. Manipulation is the passive movement of a joint to determine the range of extension or flexion of a part of the body. The physical examination is fairly standard. Variations may occur depending on the provider's specialty, the reason for the exam, and the provider's preference. Patients are more cooperative and less anxious if they understand what is expected of them. Start by giving the patient a brief explanation of the examination process. Many healthcare facilities provide the option for patients to have a chaperone present during physical exams. Assemble all supplies and instruments needed for the examination before the provider enters the room. As the provider proceeds with the examination, make sure the patient remains unexposed by adjusting the drape and gown as needed. During the examination, the medical assistant assists the provider by handing him or her the correct instruments and needed supplies. When the provider begins the examination, the medical assistant should keep conversation to a minimum and remain inconspicuous. The examination usually starts with the patient seated at the end of the exam table or in the Fowler position if the patient needs support. If the provider uses reflected light, the light source should be behind the patient's right shoulder. If illuminated instruments are used, standard overhead lights are usually sufficient. Take care not to shine a light directly into the patient's eyes. This can be done by turning on the lights while they are directed away from the patient and carefully moving them towards the lighted area. So the first thing the provider is going to look at is the general appearance. The provider starts the physical exam by observing the patient's appearance using the inspection technique. The general appearance explains whether the patient appears well and in good health, or if they appear sickly and ill. The patient's gait often provides important information. The patient may limp, walk with the feet wide apart, have a shuffle step, or have difficulty maintaining his or her balance. Posture is also checked for indications of pain, stiffness, or difficulty with limb movement. The provider notes the body build and proportions. Any gross or immediately obvious deformities are noted as well. Sometimes abnormalities in height or body proportion may be caused by hormonal imbalances. If the medical assistant notices any of these on the patient reports, any complaints, these should be documented in the patient's health records along with the vital signs before the provider begins the examination. Speech may reveal a pathologic condition. Some basic speech deficits include aphonia, or the inability to speak because of loss of voice, which is commonly seen with severe laryngitis or overuse of the voice. Aphasia is the loss of expression by speech or writing because of an injury or disease of the brain. And dysphagia, lack of coordination and failure to arrange words in proper order, usually caused by, again, a brain lesion. The provider is going to also evaluate the skin. The condition of the skin can be a reflection of the patient's nutritional status and hydration level. If dehydration is suspected, skin turgor is checked by pinching the skin on the posterior surface of the hands. The tissue is observed to see how quickly it returns to the normal location. A delay can indicate decrease in tissue fluid, confirming the diagnosis of dehydration. Extreme dryness, scaling, extended time for wound healing, or frequent breaks in the skin may indicate some type of systemic disease. Once the provider makes the overall observations of the patient's general condition, the physical exam typically begins with the head and face and moves downward to the feet. The face reflects the patient's state and tells the provider a great deal about how the patient handles stress and illness. skull, scalp, face, and palpated for size, shape, symmetry. The distribution of hair or lack of hair and hair texture may indicate hormonal changes. Excessive hair, especially facial hair in females, indicates a hormonal imbalance. As the head is palpated, the provider assesses possible nodules, masses, or signs of trauma. The pupils are checked for reaction by shining a light into one eye at a time. If the pupils constrict equally and smoothly to a light stimulus, the provider documents PERRLA, which means pupils are equal, round, reactive to light, and a combination. The sclera is checked for color, which ranges from white to pale yellow. If the eye is inflamed, it will be evident in the sclera. Sclera with a yellow tone indicates liver disease. Movements of the eyes are tested by having the patient follow the provider's finger. If eye movement is within average range, extraocular movements are intact and documented. The ophthalmoscope is a tool that's used to examine the interior of the eye, as was mentioned before, including the retina and the intraocular vessels. Some diseases like diabetes and hypertension damage the blood vessels of the retina. The ears are examined with an otoscope covered with a disposable speculum. The external ear is checked first for inflammation of the external auditory canal or for cerumen, which is earwax. Then the tympanic membrane or the eardrum is examined and should appear pearly gray. Scars on the eardrum are frequently the result of earlier chronic ear infections or perforations. The color of the eardrum is important to the diagnosis because it may indicate fluid such as blood or pus behind the eardrum of the middle ear. The patient may be asked to swallow several times to allow observation of movement of the tympanic membrane, which occurs because of pressure changes in the eustachian tube. The eustachian tube equalizes air pressure between the middle ear and the throat. The ability of the tympanic membrane to move is crucial to the hearing process. So the mucosa of the nasal cavity is examined for color and texture. The sinuses cannot be seen, but the frontal and maxillary sinuses may be examined by firm palpation over the area and by something called transillumination with the use of the otoscope. When disorders of the eyes, ear, nose, and throats are observed, the provider believes that the condition warrants the attention of the specialist. The patient is referred to an ophthalmologist or an otolaryngologist, which is an ear, nose, and throat specialist. Speaking of mouth and throat, the mouth or oral cavity is usually thought of in terms of oral hygiene and dental care. Dental hygiene includes the condition of the teeth, how the patient cares for the teeth and gums, and whether the teeth on the upper and lower jaws meet properly or occlude for chewing. Healthy gums are pale, pink, glossy, and smooth and do not bleed when pressure from a tongue depressor is applied. The palatine tonsils are usually visible. The provider may use a tongue depressor and a piece of gauze to grasp the tongue to examine it carefully. The floor of the mouth is examined by both inspection and palpation for enlarged lymph nodes, salivary gland function, and ulcerations, which can sometimes be the first sign of oral cancer. The inside of the cheeks and the gum line are also examined for any abnormal marks of color. The provider may use the otoscope light to help with this examination. The neck should be examined for range of motion by having the patient move the head in various directions. The thyroid gland is given special attention for symmetry, size, and texture. The provider manually palpates the thyroid area while the patient swallows several times because this action elevates the thyroid lobes. The carotid artery is palpated and auscultated for possible bruits. The lymph nodes are palpated. Lymphadenopathy can occur if the patient has an infection in the face, head, or neck. While the patient is still in a sitting position, the chest, heart, and lungs are all examined. The chest is examined for symmetric expansion. Tape measure may be used, especially if variation exists between the upper and lower chest expansion. A patient with a history of emphysema may have what's called a barrel-shaped appearing chest. This will be discussed further when we talk about the respiratory system. The provider may use percussion to determine the density of the lung tissues. Placing a stethoscope on the patient's back, the examiner auscultates lung sounds. The patient is asked to take deep breaths, regular breaths. This may produce slight dizziness, but the patient should be assured this is only the result of deep respirations and will rapidly pass. The provider should note the type of respirations and the presence of lung sounds in all lobes. Because considerable concentration is required to interpret heart sounds, the provider must have complete silence when listening to the patient's heart. The patient should be advised not to talk during auscultation. In patients with heart disease, the provider may spend an extended time listening to heart sounds. If lung or heart abnormalities are found, the provider typically orders further diagnostic tests, including blood tests, EKGs, and possible ultrasounds. Once the results of these tests have been analyzed, the provider may refer the patient to a cardiologist or a pulmonologist, depending on the condition suspected. For the abdominal part of the examination, the patient is lowered to the dorsal recumbent or supine position, and a drape is lowered just to the pubic hairline. The gown is raised just under the breast. The patient's arm may be placed at the side, or the hands may be crossed over the chest or under the head. Relaxation of the abdominal muscles is needed for the abdominal examination. To assist in this goal and to promote patient comfort, a small pillow can be placed under the head and knees. The provider auscultates the abdomen in all quadrants to confirm the presence of complete bowel sounds and palpates the abdomen for any abnormalities. The provider may also use percussion to determine the density, position, and size of the underlying organs. The patient's reflexes are checked with the patient sitting in the Fowler position or supine. While the patient is sitting, the biceps are checked with the patient's arm flexed and supported by the examiner. The knee jerk, patella reflex, and the ankle jerk, not meant as an insult, Achilles reflex, are checked using tapotment or tapping or percussion movement, either with the fingers or a reflex hammer. Plantar reflex, Babinski reflex, and Chaddock reflex are tested with the patients in upright position as well. Careful breast examination is part of the physical examination for every female, even if she's asymptomatic. The breasts are examined both by inspection and by palpation with the patient in the supine position. The arm on the side that is being examined is bent and tucked under the head. Breast cancer is the most common malignancy in women, and early detection is the key to successful treatment. This is a good opportunity to discuss and reinforce the consistent use of monthly breast self-examination, or BSE. For male patients who have reached puberty or 14 years age of older, the provider should perform a testicular exam as well. Testicular self-examination is an important self-examination for all males to perform each month because testicular carcinoma, although rare, is a major health risk that has a high cure rate if it's discovered early. The rectal examination usually follows the abdominal examination or maybe be part of the examinative genitalia. Preserving the patient's comfort and dignity is vital. For this part of the examination, the provider needs gloves and some water-soluble lubricant, such as KY jelly or Surgilube. The examination light should be directed at the perineal area during the examination. Fecal occult blood test specimens are often collected at the time of the digital rectal examination. If the procedure the provider performs, be sure to include the necessary collection folder with the examination equipment. Patients diagnosed with GI disorders or gastrointestinal disorders may be referred to a gastroenterologist. So with just some closing comments, medical assistants really play a vital role in the physical examination process. Having good communication skills helps in all aspects of the physical examination. Being familiar with the supplies needed and making sure that they're available in the examination room makes the process more efficient. Using good body mechanics helps to protect you and your patient. Using what you learned in this chapter will help you make a valued medical assistant. The physical examination process is an excellent time for the medical assistant to assess the need for patient education. This assessment should be performed to identify the best ways to meet the patient's needs. When identifying these needs, consider the following: the information the patient needs to know, how to convey the information so that the patient understands it, how the patient will use this information, whether any community resources are available that might help the patient understand and learn more about health problems or treatment protocols. If you can't develop a plan to teach the patient, think about the different modalities available, such as pamphlets, pictures, DVDs, demonstrations, websites, community resources, social media. The more interesting the information, the more fun it is to teach the patient, and the more enjoyment the patient will get out of learning this. Many facilities keep patient education files that contain handouts on a wide range of health issues. The medical assistant should always review teaching plans with the provider and follow the provider's direction in patient education. And just remember that the medical history is a confidential record that can be shared only with healthcare personnel directly involved in the patient's care. data provided to you by the patient or that you read in the patient's health record are confidential. You must not share any of this information with anyone that's not involved directly in their medical care. Consequences for disclosing private information to individuals not involved in the patient's care can be very serious, can result in the loss of your job, court-imposed fines, and even criminal charges. So in addition to maintaining patient confidentiality, consistently implementing correct documentation procedures is crucial for medical practices. The medical record is considered a legal document, and court cases can be won or lost based on the clarity and completeness of staff documentation. It is essential that medical assistants document all patient information in a factual, non-judgmental manner. And remember that the ability to communicate effectively is crucial to the role of the professional medical assistant. It allows for excellent customer service. Now, we've talked about customer service. Effective communication includes the use of all the therapeutic tools discussed in this chapter. The professional medical assistant should do the following. Watch for nonverbal behaviors to verify congruence between what the patient states verbally and demonstrates via body language. Modify communication methods as needed to meet the needs of a diverse patient population. Use restatement, reflection, and clarification to gather pertinent and comprehensive patient information. Use electronic communication appropriately and effectively. And that is the end of this chapter. If there are any questions, please bring these questions to class on next session, or post them up in the discussion board, or reach out to me via email. And with that, please enjoy the rest of your week and study hard. Good night.